What's up, everybody, and welcome to this week's edition of Da Vinci Cases. Alright, so the way this works is we've got a clinical case followed by a board-style question. So we're going to go through the question stem, point out the relevant clinical findings, take a look at the question and the answer choices, and then kind of divert for a minute and go through the relevant concepts to answering the question. Then we'll come back and apply those concepts that we went over to answering the question. Alright, so for this case, we've got a 28-year-old woman with no significant past medical history is brought to the emergency department after a motor vehicle accident. So this is a young, otherwise healthy woman that's been in a trauma. So the patient is awake, alert, and oriented times 4. So this is good. You always want to evaluate mental status, especially in a trauma patient. One thing, she could have hit her head, so that's one thing that can obviously affect mental status. Also, having decreased perfusion to their brain due to hemorrhagic shock or things like that. Or they could have had a traumatic injury to the carotid arteries or the vertebral arteries supplying the brain. Her vitals, always important to evaluate along with mental status when the patient comes in as a trauma. 37 degrees Celsius, so she's afebrile, heart rate of 107, so she's a little bit tachycardic, nothing too crazy, but that's to be expected with a trauma. She's 136/88, so her blood pressure is a little bit high. She's otherwise healthy, so this is a little bit high for her. Respiration of 20, so this is relatively normal. And then her O2 sat is 98%. So at this point, she's stable. That's the big thing, when you're triaging trauma patients, are they stable or not? So her mental status is baseline. She's afebrile. She's mildly tachycardic, mildly hypertensive, breathing fine on room air. So she's stable. She's in okay shape despite what she's just been through. Usually these patients get a bunch of scans. So she's got some x-rays. They reveal 2 broken ribs, treated non-operatively. So whenever you see broken ribs, you definitely want to be paying attention for pneumothorax. So she gets a full body CT, or the famous pan scan, as we call it in radiology. It doesn't reveal anything. So luckily for her, she doesn't have any internal organ injuries. She doesn't have any internal bleeding. So that's good. So she's in good shape. Her vitals are stable. Her mental status is stable. There's no internal hemorrhage, which is good. So she has a central venous catheter that is placed, and then a complete blood count, CBC, and complete metabolic panel, along with a urine drug screen, are taken before the patient is taken to the surgical intensive care unit. So this is common for patients that have been in traumas to be sent to the SICU or the surgical intensive care for close monitoring. Although this patient isn't crashing, unfortunately with trauma patients, their status can change. So it's always a good thing to watch them and keep an eye on them. However, 30 minutes after the patient arrives in the SICU, she develops acute, severe shortness of breath. She begins breathing rapidly using accessory respiratory muscles. That's never a good thing. When you see a patient using accessory respiratory muscles, that means they are in respiratory distress. So she is in severe shortness of breath. She's breathing really fast. In this type of scenario, you want to get another set of vitals, and that's what they give us here. So her temperature is 37 degrees Celsius, so she's still afebrile. Her heart rate's considerably higher now. It's 135 versus 107. Her blood pressure has dropped significantly. It's 86/60. So before she was mildly hypertensive, now she's hypotensive. So this is pretty concerning. Her respiration rate is pretty high at 30, and her O2 sat is not good at all. It's 86% on room air. So this is definitely a patient in respiratory distress. This is a patient where if you don't do something quickly, this is a patient that could crash very, very quickly. So they do an exam. It's notable for distended jugular veins and respiratory distress, which we talk about. Distended jugular veins is not a good thing. It often can mean that the right heart is not pumping. And remember that the jugular veins drain into the brachiocephalic veins, and then the brachiocephalic veins form the SVC, and that drains into the right atrium. And then, obviously the right heart pumps to the lungs. And so if there's some kind of either obstruction in the pulmonary vasculature or in the right heart, or the right heart isn't pumping efficiently, that can cause backlog of fluid, because it's just like a pipe system back into those jugular veins and cause them to distend. So this is not a good sign. Hypotension with hypoxia and distend, definitely want to be worried about some type of acute thing affecting the lungs or the pulmonary vasculature. The CBC and the CMP are normal. So the CBC, the fact that the CBC is normal tells us that she is not anemic. So that's a good thing. If, her hemoglobin was like 3, you definitely would want to scan her again and be worried about, that she's hemorrhaging. Although the initial scan didn't show anything, It's only been 30 minutes. Theoretically, she could start bleeding, but thankfully her CBC is normal. CMP is normal, so she doesn't have any too crazy electrolytes. And then her urine drug screen is negative. So that's important. That, you could think if someone goes into, where she's compromised, her respiratory status is compromised, maybe she had, taken some illicit substances, before the accident. It could have, now come into full effect. So the fact that urine drug screen is negative is also important as well. So it tells us that it's not due to some type of substance that she consumed. So the question is, which of the following is the most likely pathogenesis of this patient's condition? So we kind of have to figure out what is going on here and then kind of deduce what these different causes are. So this is a question that really, you got to really be good at deciphering the clinical data and really putting it all together and what it means, and then using that to cross off these answer choices. So like we always do, we got to just summarize things. So it's a young trauma patient with 2 broken ribs that are treated non-operatively. That's important because, surgery obviously introduces all other types of potential complications. So at this point, she hasn't been treated with any surgery. She was initially stable on presentation, but she rapidly becomes critically ill with respiratory distress. This patient also develops hypotension with distended veins, suggesting a right-sided heart failure potentially. Her CBC was negative for anemia, and her CT didn't demonstrate any internal hemorrhage. And her urine drug screen was negative. All right, guys, we're going to take a quick break from the case right now to let you know that Da Vinci Cases is brought to you by Da Vinci Academy, which provides online video courses for the medical basic sciences. These courses are taught using a variety of teaching methods, including bullet point outlines, diagrams, radiology images, and chalk talks to explain the fundamental concepts. We then teach the application of those concepts to numerous clinical pearls that are frequently tested on medical school exams and the USMLE. Our video courses are available on our website, dviacademy.com, as monthly subscriptions starting at $9.99 per month. Each video course has a corresponding outline format textbook as well. You can find the link to our website in the description below. Also, be sure to use the discount code DC20 to receive 20% off any of our video courses. Now back to the case. If we come back to the answer choices here, we've got right heart failure is what we're looking at because we're hypotensive and we have these distended veins. So we're definitely considering that. She's in severe respiratory distress. I would say the big thing you want to be thinking about with that when you have respiratory distress coupled with right heart failure is pulmonary embolism, no doubt about it. And I mean, this is something that any type of trauma patient you want to be thinking about that. And as you kind of peek at the answer choices here, there's actually a couple different things that, the classic thing we think of is someone gets a DVT in their leg and it travels up, and you certainly want to be worried about that. But as we'll go through here, there's some other causes that can cause pulmonary embolus for trauma patients. This first answer choice, thrombosis occluding the right coronary artery, that's a myocardial infarction. It's an MI. I mean, look, this patient is a young patient. She doesn't have any other notable past medical history. There's no mention of congenital heart defects. Her urine drug screen was negative, so it's not like, she consumed some type of substance like cocaine or that could have induced a myocardial infarction. She's otherwise young. You typically see these substernal chest pain. She's not complaining of any chest pain. In older adults that often have, multiple risk factors for cardiovascular disease. Pneumothorax, definitely a consideration in a trauma patient. The thing is, you got to pay attention. When trauma patients, usually, especially penetrating trauma, is you think about tension pneumothorax, where you actually have like some type of, external injury to the pleura. Spontaneous pneumothorax, if you recall, is actually when you have trauma inside. So if you have your lungs like this, and then you've got your ribs. This is like a coronal section, and then you got your pleura, surrounding. So a tension pneumothorax is when you break the pleura from outside. Typically, it's typically like a stab wound, gunshot wound, some type of penetrating trauma to that outside. Spontaneous, however, is more common in patients with COPD, emphysema, where you've really broken down that pulmonary structure and architecture. Or patients that are on ventilators, so patients in the ICU, patients that are intubated, the settings are set too high where you're basically flooding too much air in there. And essentially what happens is, you have these alveoli, these little, balloons or sacs within the lungs. And what happens is they pop. They essentially pop and they let air out into the pleura here. Now, the thing is this patient doesn't have COPD. She's not on a ventilator. And then typically you're going to see a pneumothorax on imaging. You're going to see, a pocket of air in the pleural space, and it's going to be very clear. You can even see that on an X-ray. You can much more easily see it on a CT scan, and you just don't see it. She got a full body scan, so that means she would have had her lungs scanned all the way top to bottom, and they just don't see that. Aspirated mucus, occluding the right primary bronchus. So this could definitely send you into respiratory distress. This would be, an aspiration. And this can happen in trauma patients. It's more common if the patients are altered. It's, like we say here. It's very common in, like nursing home patients, elderly patients, alcoholics, patients that, are, again, just are either altered mentally or they're not moving very much. They're just kind of lying around in bed, things like that. Again, the imaging would have showed mucus plugging and inflammation, around that primary bronchus. Again, this certainly could cause someone to go, especially if they aspirate, they could very easily quickly go into respiratory distress. But again, this just doesn't seem to fit the clinical picture. Again, it's all about interpreting the clinical picture here and what it means. So this just doesn't fit. So fat embolism, this is common in patients with long bone fractures. So yes, she did have some fractures, but there were the ribs. The ribs aren't typically considered long bones. The long bones are, like the femur, humerus, tibial fractures, those type of, long bones in the extremities is typically, clavicle also could potentially be considered a long bone. And so what happens is, the bone marrow has a bunch of fat in it. And so the bone breaks and the bone marrow releases fat into the circulation. And so what happens is that you have this clump of fat that goes up, just like how a clot from a deep vein in the leg would go, it goes up through the venous system and gets clots off in the pulmonary vasculature. A frequent association with a fat embolism is patients who undergo orthopedic operations. So especially they say like, a patient comes in after a car accident, they have a broken femur, they went to surgery for surgical fixation of the fracture, and then they developed this triad afterwards. So hypoxia, so definitely, respiratory distress. They often have neurological symptoms. Patient who was otherwise had normal baseline mental status, ANO times 4, they become confused, they're lethargic. And that's because essentially you're spraying these clots. You can, essentially you'll spray them to the lungs, but then you can spray these fat clots into the brain, and that can cause these type of symptoms as well. And then this petechial rash, because these clots are going to the skin as well. And so if you see this triad in a patient that had, a long bone fracture, that especially if they underwent surgical fixation with orthopedics, that's kind of a slam dunk for a fat embolism. And you just don't see that. She had some fractures. They were treated non-operatively. She didn't have a femur fracture, humerus fracture, anything like that. She didn't have any orthopedic procedures. She doesn't have any, they're not mentioning a change of mental status. She doesn't have this rash. She does have hypoxia. So it doesn't seem to be the case here. So this last one, air embolism, occluding the pulmonary outflow tract. So this is commonly seen in patients that receive central venous catheters. Now this is going all the way back to here. Now, this is something you could easily blow by. Now, it's not uncommon to get central venous catheters, and we'll go over what central venous catheters are in more detail. You probably have some idea, but we'll give you a little bit better picture. It's a term that gets thrown around a lot in the hospital, and we'll just clarify that for you and why this is important. So again, this really goes back to that you got to pay attention to every detail in these stems very, very frequently. Every single detail is put in there for a reason. Again, it's very common to put a central venous catheter in a patient going to the surgical ICU. But that being said, you will, when you see that, you want to keep in mind the risks, that puts them at risk for an air embolism. And so the other thing is like IR procedures, interventional radiology procedures, because again, with those procedures, we are often accessing either the arterial system or the venous system with catheters that could obviously introduce air. Cranial surgeries as well can place patients. So, neurosurgeons, for example, so like a trauma patient ends up, having like a subdural hematoma drained. So this is just a diagram to illustrate the placement of a central venous catheter, and then also explain to you how you can introduce air and cause an air embolus. So a central venous catheter, or CVC, central just means that it terminates centrally, meaning that it terminates at this cavo-atrial junction, the junction of the SVC and the right atrium. The idea is to introduce, fluids, medications directly into the heart, so those can then get pumped quickly out to the rest of the body. When you're placing these, kind of the main purpose is to give yourself direct access to give, like I said, fluids, meds, You can also take labs, venous labs. So you can't take like an arterial blood gas. You could take a venous blood gas. You could take other labs. And the nurses really like these because it makes their job a little bit easier. They can just quickly give meds. And these are typically larger caliber than just your standard peripheral IV. So you can give larger boluses of fluid, larger boluses of meds. You can also have 3 different lumens, as we show here, that kind of run down, and you can introduce, you can be giving fluids, meds, all of the above, or 3 different types of meds or more. You can have 4 ports as well. So these are the different ports. These are where you would introduce, fluids or meds, and they connect in here where they're joined together and kind of run together in this portion here of the catheter that then terminates down here. You place these catheters by first you use ultrasound guidance, and then you have a needle and you pierce the skin, typically at the base of the neck, to access the internal jugular vein. It's a nice big vein. We can easily see it on ultrasound. You can also do it in the subclavian vein as well. So then when you access the vein with the needle, then you run a wire through it, and you have a wire that kind of runs all the way down here, and then you place the catheter over the wire to have it terminate down here. When you're placing the catheter in, that's when you can introduce air. So you always want to be very careful that, so each of these ports has a lock on it, and then you can actually put a little cap on them too, as we'll show on the next slide, because I'll show you a real picture of one of these catheters. That's where you can introduce air. So you're always careful to cover these. As someone who's put in a number of central lines, you always want to be cognizant of the fact that you can introduce air, and you want to be covering these as much as possible. Because you could see, if you leave this open, air can come in, a little bit bubble of air comes in, and it comes all the way down here, and then it goes right into the right side of the heart, and then it can go right into the pulmonary outflow tract and obstruct that, or the pulmonary vasculature, and cause a pulmonary embolus, as you can see. So this is just a real picture of a central venous catheter, just to give you a better idea. So when you do your rotations in the hospital, you'll see these. So this is again that point where you have these ports that come off. So this is a triple lumen catheter. There's quadruple lumen catheters. There's dual lumen catheters with just 2 ports. Here's each of these ports. You can see these little locks like this. Here's those caps I was talking about. So through each of these, you can give meds, fluids, take labs. And again, you'll see the nurses, when after they give meds or give fluids, they are always certain to cap these off and lock them so that you're not introducing. Because even when the patient's just sitting in the room, not necessarily during the procedure, afterwards, if it's just sitting there, you can have air introduced that way as well. And you can see, air comes in, comes all the way out, and it can come out this way and again and be introduced right into the heart. So to come back to this is a patient that was a trauma patient, came in after a motor vehicle accident that was initially stable, had a central venous catheter placed that introduced an air embolus in and ended up causing pulmonary embolism. These are patients that, if this isn't dealt with immediately, this can actually be fatal. These patients can code pretty easily. It's something not to take lightly. One thing you can do that's kind of interesting from an anatomy standpoint is, so if you have the heart like this, so this is the right heart, and this is kind of just a crude drawing. So here's your tricuspid valve here. Here's your pulmonary outflow tract here. So that's where the pulmonic valve is going to be. So here it's talking about it's occluding the pulmonary outflow tract. So if you have it like this, what you actually do is you turn the patient into left lateral decubitus. Essentially, you turn them on their side, because remember, air is less dense than fluid, so it's going to flow upwards. So versus here where they're lying supine, if you turn them on their side, the heart is going to be like this. So again, here's the tricuspid valve, here's the right ventricle, again, right atrium, right ventricle, right atrium. And the thought is that the air bubble will move off of the pulmonic outflow tract and get caught up here instead of obstructing blood flow outflow to the pulmonary vasculature. That's something immediately you can do when the patient's on the table or in the bed, is you can turn them into a left lateral decubitus position to help prevent this from getting any worse. I don't know if that's necessarily something you'd see on a USMLE Step 1 or even Step 2 question, but it's just kind of a good practical thing to know. So I'll leave you with that. All right, that's all I have for you this time. Be sure to check out all the Da Vinci Cases videos available on our YouTube channel and our website, dviacademy.com. The PDF notes for every Da Vinci Cases is also available on our website. Also be sure to check out our podcast, The Da Vinci Hour, where we interview attendings and residents across medicine to learn more about their experiences, their specialties, and to get their insights on navigating a career in medicine. You can find the Da Vinci Hour podcast on our website or any platform where podcasts are found. Lastly, you can find all of our video courses and corresponding outline format books on our website. Don't forget to use the discount code DC20 for 20% off.